there's a disaster that the radiologists say, suddenly you're our problem. It's really exciting. Rarely do you get follow-up on your patients. Rarely do you know what happens to them. The upsides of emergency medicine are you never know what you're going to do when you come to work. Now, for many people, that's a real downside. Yeah. And I know that our best nurses did a stint in the ICU, but most ICU nurses cannot work in an emergency department because they don't have any control. You never know what you're going to do. You're constantly intellectually stimulated. Every patient is a new patient, and never assume that the diagnosis that they come in with is correct. You get a chance to fix somebody else's mistake and help the patient. So when you come in and you say, I have this, when the docs start working it up, don't assume. We never assume that what you say you have is what you have. Hopefully it is, but we'll find stuff you don't expect. You work with an incredibly intelligent and motivated people. The nurses, the docs, the secretarial staff, the technicians are all fabulous people. They're incredibly motivated. You have to be an actor. I'll come in and I'll see a 2-year-old kid who's terrified, and I got to make a friend with him to do a decent exam. You can see that patient, then you can go in and sit down and tell somebody they have cancer. And then you get out and you go to the next room and you got a drunk who's spitting at you. You got to be a different person in each of those situations. You have a flexible schedule. We work days, nights, weekends, holidays, but you can take a week off or 2 weeks off anytime you want. Your colleagues fill up the shifts and you fill them up for them. So I had the opportunity to take a month off every year for about 7 years and travel all over the world. About the emergency department is a physical plant. Right now, there's about 20 doctors, about 90 nurses, about 40 techs, 30 secretaries. There's housekeepers, x-ray techs, lab techs, psych techs, social techs, and others. And there's also a never-ending collection of medics, firefighters, and first providers who parade through. It's a team. You work as a team. I always thanked anybody who called me on something. If somebody said, "Why are you doing this?" I would justify it. And every once in a while they would say, "Why are you doing this?" And the response is, "Oh shit." Thank you. So it's a team. It's an environment of controlled chaos. Things can change in a minute. They often do. I can remember taking care of a patient, and all of a sudden, in one of the critical care rooms, and all of a sudden, one of the nurses comes running in with a baby in cardiac arrest and puts the baby on the top of the laundry hamper, and we shift our gears. Pre-planning in the emergency department, I'm often asked about that. Some things are done by recipe. If you have a heart attack, we know what to do. We have the steps, and everybody knows. Trauma is a big one. Trauma is all pre-planned. If there's a trauma coming in, we get notified by the medics. Frequently we'll get pictures of the scene. We'll get before they arrive, and we muster our team. And the trauma team includes an emergency physician, a trauma surgeon, 3 nurses, 2 techs, an x-ray tech, a lab tech, and we're all in the room. Everybody has their role. They know what they're going to do. They know where they go. And we just go through the process. Nobody raises their voice. Nobody yells. We just go through the steps of the process to find out what's going on and take care of somebody. The emergency doc, which is the role I played, in those are responsible for airway management, management of vital signs. We make sure you're breathing, we make sure your blood pressure's okay, we resuscitate. The surgeons look for the problem, and once we've got the patient stable, we turn to the surgeon and say, what do you want me to do? And we move through the process very quickly. We can get somebody in and through CT scan in 20 minutes. Often we can get people to the operating room in 20 minutes. If somebody comes in and they have a gunshot wound to the belly, stabilize them up to the OR. And we'll do that in 15, 20 minutes. Strokes have a protocol. When somebody comes in with a stroke, it's billed as a stroke by the medics, one of the docs meets them in the hallway on the ambulance gurney. We do a quick exam, we get vital signs, blood is drawn, and they're taken by the medics to CT scan so that we can get a CT scan and see if they're a candidate for thrombolytic therapy, which is the blood thinners. Heart attacks. If we see an EKG with a heart attack, we can have somebody in the cath lab, depending on the time of day, in 10 minutes, 15 minutes. We have a door, one quarter we were #1 in the nation for door to balloon time. So that's it, from the time somebody comes into the door until the time they got their stint in. The national standard is 90 minutes, and I think we did 46 minutes that quarter. A couple of cases, just interesting, these are all burial cases. I was working at a little hospital, not in Santa Rosa, and some kid came in with his tongue stuck in a Coke bottle. So he sucked on the Coke bottle, stuck his tongue in, and of course the vacuum holds his tongue in, and it obstructs the venous outflow, but the arterial flow keeps going in. So this is a little 17-bed hospital. I'm the only doc. The buck stops here. What are you going to do? They never taught me this in medical school. What the hell do they do? So what I did is I got a little tiny pediatric feeding tube, greased it up with lidocaine, threaded it down beside the Coke bottle into the inside to relieve the pressure, took a giant syringe and pushed the plunger as hard as I could. And after about 3 or 4 minutes of this, all of a sudden, bam, the Coke bottle blows off and flies out onto the floor, busts on the floor. What?
How was his tongue?
Well, it was fine now. It wasn't before. Yeah, stop me if you have questions. I had another case many years ago where I admitted a patient to the hospital. He came in with new atrial fibrillation. Atrial fibrillation is a rhythm, it's irregular, and you lose a lot of efficiency with blood pumping. You lose about 30% of your cardiac output, but you also put yourself at much higher risk for strokes in the future. And so we usually try and take control of that. So I admitted this guy to the hospital and sent him up to the floor with the hospitalist to take care of him. Usually this is a pretty routine thing and you go through a little process. About 2 hours later, they call a code blue, and I go into the room where this guy, where I just admitted, is there. And he's struggling to breathe, he can't talk, he can't get enough breath, he's got a blood pressure of like a 90 or 80, and his heart rate's about 130, and his oxygen saturation is like 56%. This guy's gonna die if I don't do something. He's gonna die. There's no question. So what goes through your brain is, what can this be? We set up what we call the differential diagnosis. So you make a list of all the things it can be. And the two things that come to the top of my head are, he's having a heart attack, he's got a pulmonary embolus. Those are the two things that have got to be at the top of the list. His EKG is normal and his chest x-ray is normal. He's dying in front of me. He's trying to die, as we say. And so I called the pharmacy and asked for TPA, the thrombolytic, with the PE protocol, pulmonary embolus protocol. Gave it to him, got him into the ICU. 2 hours later, he's normal. In the morning, they squirted his coronary arteries, normal. They did a CT angiogram of his lungs looking for a normal. We never knew what happened. We have to assume that what I did was right. If this guy had bled in his brain, which is one of the side effects of TPA and is essentially fatal, I had no justification for what I did. I mean, there would have been a lawsuit out of that. But I did the only thing I thought I could do to save the guy, and he walked out of the hospital.
What is TPA again?
Tissue plasminogen activation.
Yeah.
What?
It's tissue plasminogen antigen. It's a thrombolytic. It's a drug that dissolves blood clots in the body, but it dissolves blood clots everywhere. So if we give it to you, if you have a little tiny bleed in your brain, a little bruise, you'll bleed in your brain. If you have a GI bleed, you're going to bleed. And there's no reversal for it. So it's a very dangerous drug that can do wonders. I had another case many years back where a guy came in with back pain. So this guy's probably 60 years old, probably weighs 350, maybe 400 pounds. And he has terrible back pain. Well, we see 2 or 3 back pains a day. And working up back pain is one of those problems that's fraught with risk. If you have what we call cauda equina syndrome, which is where the nerves at the bottom of the spine get pinched, you can develop paraplegia, functional paraplegia. You lose control of your urine, you lose control of your stool, you can't stand on your heels, you can't get your toes off, so you can't walk right. So this guy who, sees a doc every 40 years, whether he needs to or not, I do an exam, and now we're looking for this all the time. I've seen three cases in 33 years. Every patient we see who has back pain has it until we prove otherwise. This guy looks like he's got cauda equina syndrome. So I send him to MRI, and we practically never order MRIs out of the emergency department because they take forever and you don't get results right away. And we do the MRI, and he's got cauda equina syndrome. So I call in the neurosurgeon. And the neurosurgeon comes in, and these people need surgery right now, like right now. And the neurosurgeon, and I also call the hospitalist, who's a gorgeous young lady, and she comes in to see him. Oh, by the way, his blood sugar is 400. His blood pressure is like 160 over 110. Everything, he clearly is a medical nightmare. And the neurosurgeon sees him and says, he's got cauda equina syndrome. Hey, Stu, he's got cauda equina syndrome. And I said, I know, that's why I called you. But he's not going to let me operate on him. And of course, this is Friday night at 9 o'clock. It's always some bizarre hour. And so the hospitalist comes out and says, he's not going to go to surgery. And they both said that they told him about all the complications. And I said to him, did either of you tell him you might never get an erection again? No. So the hospital says, I'm not going to tell him that. And so I said, well, I'll tell him that. So I went in and I sat down in the good cop routine. I sat down, relaxed, and I said, you know, I know you don't want to hear any of this. You don't want to know anything about this. You don't want to have surgery. But I look for this my whole career. I see one or two, we see them very rarely, but it's the most important thing we see for back pain. Look for back pain. And you have it. And if we do everything right, you still may be a functional paraplegic. But if we don't do it, I'll guarantee you'll be a functional paraplegic. You'll never have control of your bowels. You'll never have control of your urine. You'll pee on yourself and poop on yourself. You won't be able to walk, and you probably will never get an erection. And while I'm in there, this neurosurgeon comes in, and he's anxious, and he wants to go home, and it's Friday night, and he don't want to get called in at 3 in the morning to do this thing. So he comes in and says, now come on, you got to decide what you're going to do. I don't want to be here to come in at 2 o'clock in the morning to do this, so if we're going to do it, we're going to do it now. And this guy looks up at the surgeon and said, what time's the surgery? Another case, I was out at a little hospital. We worked occasionally at a couple of little hospitals in the community. And a guy was brought in by the medics who was shot in the tongue. His wife shot him in the tongue with a .22. I don't know why, but anyway, and we don't ask those questions. You know, we're not the detectives. We're not the cops. We don't care how it happened. We just don't want to fix you. The cops can tell us later if they want to. Anyway, so the guy came in on all fours on the ambulance, on his knees and hands and knees, bleeding out of his mouth. And you look in his mouth, and his tongue fills his entire mouth. It's the lingual artery is hit, and it's okay. I'm in a 17-bed hospital out in the middle of nowhere, and the buck stops here. He'll die if I don't do something. I got to get an airway into him to make sure that he can breathe. He can't roll over because his tongue falls back and he's bleeding back there. I can't roll him over. So I try and intubate him, which is put the tube down into his breathing tube, with him on all fours. And what you do is you shove it up in his nose and down, and the curvature of the tube, if you just time it right and you listen as you advance it, when they take a breath in, you can slide it into the trachea. Well, the tongue was too swollen and kept pushing the tube back, and every time I would try and put it down and advance it with his breath, I'd block his airway. So I'd pull it out. So then I took an NG tube, a nasogastric tube, and I threaded it in the other nostril. And I threaded it down into right at the level where the endotracheal tube was. Then I could roll him over. He could breathe through the endotracheal tube, and the NG tube kept sucking the blood out. So we kept his airway clean. We rolled him over, and I did a tracheostomy on him. And I got the tube in his trachea, or what we call a cricothyrotomy, but it's basically the same thing. I got the tube in there, and got the balloon blown up. Then I got a cervical collar like they have for patients with neck injuries, and I put that on them, and I taped it all the way around, and I taped the tube so there's no way anybody could pull that thing out. And I called the helicopter. I never heard what happened to him, but I'm sure he did okay. He had an airway, and the injury was not that significant.
Maybe his wife was happy he survived.
Gary says maybe his wife is happy he survived. Recently, in the waning years of my career, I had a guy, I came to work a 5 o'clock shift, and I had a patient who was signed out to me. Oh, he's drunk, let him sober up, take him for a walk and feed him a meal, and you can discharge him. So after a couple hours, I got him up and I said, let's go for a walk. And he walks into the wall. Why'd you walk into the wall? Can't see it. What? I get out on a ophthalmoscope, one of those little things with looking eyes. I got out an ophthalmoscope, and he's got dense cataracts. So here's a homeless guy who's newly blind. His blood alcohol is 0. What do you do with him? What do you do with him?
Cataract surgery.
Yeah, right. So it's Saturday night at 9 o'clock. What am I going to do with him? I can't send a homeless guy who's blind to the street. So I texted our utilization review doctor, and that's the person in the hospital who reviews all the cases to make sure that they were appropriately admitted. And I said, interestingly, I texted him and I said, Al, you're not going to like me in the morning, but it's my fault. Because usually they ding the hospitalist for admitting him. And I called the hospitalist and I said, you don't have a choice. So this guy got admitted to the hospital. I called the ophthalmologist and she said, sure, I'll fix it. No problem. But Memorial doesn't have the equipment for doing cataracts. And so he was in the hospital 2 weeks. They transferred him to Petaluma where they could do the surgery. They did his cataracts down there. The ophthalmologist wouldn't allow us to discharge him because he couldn't do follow-up. So he got transferred back to Memorial and spent another 2 weeks at Memorial. Turns out Medi-Cal paid for him until he got his cataract surgery because he was newly blind. But as soon as he had the surgery, they wouldn't pay for him. So the hospital ate most of this. I never heard a word from the hospital about what I did. You always do what's right for the patient. You never think about what the cost is or what the consequences to you are. Any questions? I did. Yeah. Shoot.
Over the time that you were a doctor, you saw probably the transformation of medicine from something that was not costly to something that became extraordinarily millions of dollars to treat somebody that,
Yeah.
And so what do you attribute that whole transformation?
Profiteering.
Okay, that's what I wanted.
Everybody's trying to make a buck. The problem with medicine is it's poorly funded. If you have money, you can get the best care in the world. If you don't have money, you get the worst care in the world. We desperately need a single-payer system where the hospitals, the rural hospitals are all closing because they can't get enough money. And we're losing OB all over the place. We're losing, little hospitals are closing at a rate of a couple a year in this country.
So what does single payer look like to you?
Medicare.
It's basically Medicare for everybody.
Okay.
With that, then the institution knows that they're going to have a cash flow to be able to support them. When each hospital, how many hospitals have centers of excellence for heart attacks, strokes, cancer?
Kaiser.
Everybody.
Yeah.
How many hospitals have centers of excellence for seizures, drug and alcohol abuse? Nobody. And until you can everybody has to chase the dollar to stay open. And so it's a broken system. It's very frustrating. We as docs don't have a clue as to what things cost, or what, let me rephrase that. We don't have a clue as to what the charges are, not what things cost. So that's very frustrating. And I think a single payer system where, the Canadians are a single payer. And 86% of the Canadians love their system. Tell me if 86% of Americans love their system. So,
Thank you.
any other questions? Yeah.
Do you miss the adrenaline rush?
After about the first 5 years, there's not a lot of an adrenaline rush. It's a job. You get used to it. Yes, there are times when things happen very quickly. Are you telling me that I need to stop?
Yes.
Because I have some more stories I can tell, but the clock is running, and so I guess I need to stop. But yes, I miss the intellectual stimulation. I miss the camaraderie of the people I work with. It's a very close team. Working in that environment is something that would not be allowed in any other environment in the world. We would all be accused of sexual harassment. When I'm standing in the trauma room intubating somebody's behind me with their arms wrapped around me, holding the patient's head, and there's whoops, I turned it off. Is it back on? There's somebody's drawing blood, at the same time somebody else is leaning over them to do something on the patient. We're all touching each other all the time, Right. So.